Top Med Talk.
Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on Top Med Talk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
All right. Hello, I'm Desiree Chappell, and this is Top Med Talk. We're here in Orlando, Florida for Anesthesiology 2019, the annual meeting of the American Society of Anesthesiologists. With over 14,000 delegates, this is the largest gathering of anesthesiologists and anesthesia providers in the world. Now, I am usually joined by my co-host, Monty Mython, our editor-in-chief, but Monty, whether or not he'll tell you, won a very prestigious award and recognition for Kerry Man of the Year, so Kerry Ireland Man of the Year, and he is on his way back to join us at ASA this year. So, Monty, we miss you, but I'm sorry to say to you, Monty, but I am very fortunate to have my wonderful co-host and friend of Top Med Talk, Mike Grocott, here with me. Hi, Mike. How are you?
I'm good, Desiree.
Thank you so much. Thank you for being here. You're a friendly voice on Top Med Talk. We hear you quite a bit, so it's good.
Oh,
I love it.
I try. It's been very good.
So we are honored to have the Jeff Simmons.
Thank you.
I couldn't resist myself. So we have Jeff Simmons, who is, you were at UAB in their anesthesia department, yes?
I am still working in the anesthesia department, but have recently taken on a new job with the health system.
Oh, fantastic. So UAB being the University of Alabama, Birmingham.
Correct. The one in the United States.
The one, exactly. I was going to say the same thing. Yes. So Birmingham in Alabama. And how long have you been there?
I got there in 2013. I left the University of Cincinnati, where I had an active duty Air Force function in Cincinnati. So I was in the Air Force for approximately 10 years.
Very excited to sit down with you and hear about some of the things that you're doing. And I introduced you as at Jeff Simmons because recently you have taken to the Twitter.
Yes. And
you're shouting to the world about changing care of our surgical patients. So tell me a little bit of what has motivated you to do that.
Actually, the ASA, the conversation, Julie Thacker had said, hey, Jeff, I posted a picture of you on Twitter. And I was like, fantastic. I don't have a Twitter account. And then it actually turned out, if you look at my Twitter account, the reason that I'm at Jeff Simmons is because I joined in May of 2008. I was the only Jeff Simmons. I'm not even at 19724. You know what I mean? I'm the only Jeff Simmons at that time. And so I was like, oh, all right, well, I'm going to do this. And so I actually enlisted my daughter, who is a senior in high school, and she gave me some Twitter tips and said, this is what you have to do. I started with the mindset of passionately believing in this concept of prehabilitation, preoperative optimization. And I have been involved with enhanced recovery for several years now, and have also been running the preoperative assessment and consultation treatment clinics at UAB, but wanted to really push this agenda, push this concept, push this idea out further. And over the last couple of years, we have really been doing a lot of cool stuff. And I'm not saying that we're on the level of Saul's clinics and Duke or not nearly what they're doing. I even had posted are you a New Zealand level optimizer or a England level organizer or or just one of us? You know what I mean? And I had to put optimizer with an S on some of them because that's how you spell it.
You thought we wouldn't understand?
No, well, I didn't know. I felt like maybe what is this word? But we had started doing some really great stuff, and I started thinking to myself why wouldn't people want to know about it? And over the years, there's been so much great data and science. And Mike, you've put out a lot of that, and Tim, and a lot of the guys who have put out really great information about preoperative optimization. But it just seems like there was a lack of implementation, especially in a lot of stateside hospitals.
Absolutely.
And I am an implementer. I love to just say, let's do it. Let's try to. what would be the downside of
Right.
offering someone smoking cessation? And if it works, let's protocolize it. Let's make it into a guideline. And so we have begun over the last couple of years. We've probably implemented maybe 11 or 12 very easy to implement optimization techniques. And we've been successful. I mean, in the sense of being successful in the implementation, having a high number of patients who were identified as having that risk, that modifiable risk, and then having done what the science says to do about it. So that's, and I'm proud of UAB for doing that, and that was one of the reasons of getting on you on Twitter.
Yeah, that's awesome. Well, so tell us about, I want to hear a little bit more in detail about kind of what you've done, because we get a lot of those questions. You know, people want to know, like, how do you do this? And so I want to hear about that. But tell me how your new role that you're taking on, tell us about that and how that's going to play a part in getting people to change.
So the UAB Health System is partnering and branding several multi-specialty clinics around the state of Alabama. And they have really not had a statewide medical director for these multi-specialty clinics. So there's a lot of administrative plus clinical responsibilities that would go into really getting them on board with what UAB would like for them to do. So it's not all clinical. There's going to be some administrative parts to it. But I've had this notion that prehabilitation and preoperative optimization is really no different than just good public health. It's really great primary care with the crucible of surgery, making it something that you need to expedite, something that says, yes, you've been a smoker, and yes, you shouldn't smoke, but man, now you're about to have surgery, and there's going to be a definite consequence to that. So what a great time to stop. And then really saying, well, what if we took this idea all the way to the surgical clinics, and where they would have the information, the how-to, knowing that it's not very difficult. I mean, there are some things that are difficult.
Sure.
There's low-hanging fruit and high-hanging fruit, but if we could really push that out as far out to the actual surgical decision, like what I see is being done in England, and this is not a novel concept to probably any of our European listeners, but and they're like, yeah, of course, but it's a novel concept here.
Yeah.
And if we can really push that out as far to the surgical decision-making time frame, we could then use the preoperative assessment clinics for real fine-tuning.
Yeah.
And that would just be remarkable. I think that's when you're really going to see this explode. And so I have taken to this hashtag on Twitter, this E before S.
Yeah, I saw that.
And this idea of enhancing recovery before surgery.
Yeah.
Because if you wait till after surgery, the cat's out of the bag to some extent. There's so much we can do after surgery and intraoperatively, but I think where you're going to see the biggest bang for your buck is going to be prior.
Absolutely. So, yeah, Mike, go ahead.
Well, so I love the idea of the pre-operative clinic as a fine-tuning environment. How are you getting to your patients? How are you interacting with your patients earlier before that, such that they're ready to be fine-tuned by the time they come to the clinic?
Well, part of it is I would like to get to that concept, and that's going to be one of the things that I'm going to try to help push out to these multi-specialty clinics around the state. But locally, in the last couple of years, what we've done is just make the information of implementation or the what are we doing readily available. I was thinking about this concept on the way in, but the concepts and the how-tos of prehabilitation should be held with an open hand. Right? If you were like, I know what to do, but you don't tell anybody what to do, you might as well keep it to yourself. So holding it with an open hand for anybody who wants to know about it. And we have found so much more agreement in what's going on when we have reached out in a multi-specialty way, making visits to clinics, really bringing CRNAs and frontline providers in. I mean, and explaining to them, not so much like this is what we're going to do for prehab, explaining to them that without them it can't be done. Right. I mean, you can do so much, but if the frontline providers don't know what to do, it's not their fault if they derail it, if they have no idea what's going on. So we've tried to incorporate a lot. Also, Twitter for advertising, and then lastly, just getting our guidelines out for UAB physicians and making it easily available on the internet so that they can see our guidelines and what to do.
Well, we were talking, Mike, our first conversation today was all about prehabilitation and getting to our patients before, and that point of contemplation, really. And it sounds like those are kind of, you guys are talking the same language
notion.
here.
One of the things we discussed earlier was the, so how you target the patients that most need it, on the basis that it's unlikely you've got the resources to support everybody. And we talk about universal, targeted, and specialist interventions. But how do you? What are you using to identify those in need, and then what's the pathway for them?
I have found that there's been a lot of success in individually reaching out to service lines. So we went out for our initial foray into optimization. Okay, so ERAS separate. ERAS always starts out with colorectal, it seems like. You know? So you always do your colorectal ERAS first, and then GYN and urology, and everybody starts to build on it. I think we're now doing bariatric ERAS now. But the way that we set out with our optimization, our enhancing recovery before surgery, or I was making fun that I needed to know how to pronounce Tom Varghese' name so that when I name drop, it's going to seem like I know him. But the American College of Surgeons has a Strong for Surgery program, so I would be remiss if I didn't talk about that. But we targeted specific service lines, and we went after the total joint arthroplasties, hips, knees, and complex spine. And we said, if we could bundle, okay, so we presented it to them almost like Progressive Insurance. I think I have to give them a royalty now or something. I'm like Flo from Progressive Medicine. Yeah. So we basically said, okay, these are the...
I think they need to give you a royalty.
I know, right? Bundle and save a life. Sorry. So we took the 14 modifiable risk factors and how we would optimize them, and we did a couple things. We said, we're not just going to talk about it in this nebulous term. We're going to say what specifically we're looking for. This is the measure, right? So we're going to say we're going to do a PONS score, a POM score.
Yep.
That's kind of like when a medical student doesn't know if it's supposed to be BUN or BUN. Do you say PONS or PONS?
Okay, well, for our listeners, what does that even stand for?
It's the perioperative nutrition screening.
Yeah, nutrition screening. That's right.
That Duke does.
Duke and Paul Wishmeyer in that group.
Paul Wishmeyer. We actually do a Nestle mini nutritional assessment.
Okay.
So we don't actually do that one. But so what is the diagnosis? And then secondly, how are we specifically going to diagnose that? Third, what is going to be the treatment plan with a timeline? Okay, so it's not nebulous, right? And so when we went to go tell them, we want to do this for you, you're having a problem with, and this is hypothetical, but let's say that they were having a problem with perioperative DVTs and surgical site infections. So we said, okay, this is how we're going to help you. Then we got basically the buy-in from them, and we wanted to know this. If we identify all these things and we communicate with you, are you willing to actually delay a procedure? Are you actually willing to postpone a procedure for optimization? And they said absolutely.
Wow.
And early on, it was harder. Later on, as we've had nearly 7 or 8 months, and I can tell you about our hyperglycemia protocol, but we have had about a 7 or 8 month decline in surgical site infections for our total joints and total hips and knees, and it corresponds directly at the time when we initiated our kind of larger perioperative hyperglycemia protocol. So we're super proud of it, right?
Yeah.
And so then with that, they're like, what else can you do?
Yeah.
What's
next?
Do? Yeah. and now we're a partner, right?
Very
and
cool.
So now we're a partner, and just like anything else, just like with enhanced recovery, now we're starting to see some other surgeons come by and saying, I see that you're doing this. And we've kind of shopped it around. And so we're starting to see like GYN oncology now. They're real big.
Great.
And the Macmillan prehabilitation concepts just came out.
Yeah, we were just talking about that.
They're phenomenal, right? I'm like, I wish we could do that.
They came out this summer whenever we were at EdPump. Mike.
Yeah, early July. Yeah.
And so, but it's starting to come out. And, we were joking around. I don't know if I was there for it or if I was listening to, because, by the way, I'm a huge Top Med Talk. I'm geeking out right now that I'm on this show. I think that's so cool. But Lee Fleischer was saying, we'll know we've arrived when prehabilitation is no longer auto-corrected. And
you said that much better than I did earlier, but
yeah. So I think that we're starting to arrive, right?
So.
We're having surgeons really become interested in what we're doing. And it's only going to be through making it local, growing it. So that's how we've done it. That's how we've kind of reached out.
Oh, that is phenomenal.
And I'm willing to share any of this. Honestly, I would love to be able to share basically what we do. And I also understand this. Everyone's not going to do the same.
Right, and they're not expected to do it because it's not going to be the same for everybody. Yeah. It can't be.
I was listening to Angie Edwards talking about preoperative anemia optimization, and we at the time did not have the resources to do intravenous iron infusions, but we started small, and we started out with oral iron replacement, B12 and folate replacement, and Dr. Edwards was kind of like, maybe not as effective as you would like it to be, right? Yeah. But we've seen some benefit. Yeah. We have seen not the dramatic improvement that you would get with IV iron. And then over the course of the last probably year and a half, we've then formulated some collaborations with Hem-Onc to be able to get a patient in much sooner and get their carboxymaltose.
Well, at least you're starting the conversation with it. I mean, and that's so important that people are in creating some awareness, because that's everything that we're doing.
That's exactly right.
I mean, you have to get people on board, and it's only through those types of conversations.
They have to believe in it. They have to see it in action.
And I mean, great story, inspiring story. Barriers? What have been the obstacles that you had to overcome along the way?
Well, one of the biggest barriers, I think, is that who pays for it, especially in the United States. Who pays for it? The National Health System. I'm not even going to get into that.
We have the same challenges.
There seems to be issues. You get into some other things. There's things that you would like to do. We really wanted to get into obesity management.
Oh, gosh, yeah.
But then Americans see obesity management, you're going to starve yourself. Right, and we don't want people to starve themselves. No. We wanted to do it in a healthy way. When we looked into weight management programs, it's very expensive and almost not a possibility for things that we're going to do. Nutrition and being able to get the protein supplementation and the vitamin D supplementation into patients' hands, very difficult. We had one surgeon that was actually just saying, this is the link on Amazon Prime.
You can buy it. I was somewhere who did that.
This is how you do it. You're going to order it. They're going to deliver it directly to. And really, that's genius. As long as you have a patient population that's willing to do it.
And that can do that.
Exactly. So some barriers are going to be who pays overall. For example, we do smoking cessation, but one of the things that we do for public health is for patients that have a high stop bang score. Or patients who are on a considerable number of opioids or benzodiazepines, we will give them or prescribe for them a Narcan prescription as an emergency medication for post-operative emergency. And we describe it as a public health thing. It's for you because you're in a high-risk time where you were going to be getting new opioids. That can be paid or not paid. And if it's not paid, it might be $100.
Yeah.
Right? And so that becomes a barrier. I would say the other part of it is the overall lack of the controlled trials, the studies that say it works, right? We do all this from public health. So Mary Hahn put out a really. Oh, I'm leaning forward.
All right, let's get it.
I'm leaning forward. We're getting into it.
I can't lean forward.
No, come on.
We are.
You're fine right there.
I'm in.
So if you look at the smoking cessation, I mean, you know that there is going to be benefit for smoking cessation, but when you say that you did it in the preoperative and how did it result in postoperative outcomes, it's very difficult because it's so multifactorial. Yeah. And so you almost had that same argument with ERAS, though, right? You had 21 elements.
Absolutely.
21 elements. Which one is working? Which one is maybe countering?
Yeah.
We might be finding right now that gabapentinoids might be causing more of a delay. I do question how much they're giving, and then I start to think, why not push it out further? Why not get those patients on it so that they're not getting it on the day of getting an 800 milligram dose? Let's give it to them a week ahead of time.
Yeah.
And no one's telling us we can't, right? So other than they made it a Schedule 5 drug, but
that's actually a really good
point.
That
is a big deal. But I mean, but there's nobody that's saying that we can't.
Right.
Right.
Yeah, and you have to keep questioning it.
And Jeff, tell me, so one of the characteristics of the population you're talking about is they come back for the other knee and the hip.
True.
And what's the patient feedback? What are the patients saying about the new way of doing things?
So It's very similar to the enhanced recovery. A lot of them will say, nobody ever talked to me this way.
Yes. Oh, absolutely.
Right? And
Familiar, yeah.
the one of the comments that was made earlier was that there seems to be a dissatisfaction amongst anesthesiologists who have this limited interaction with patients. And I have found incredible satisfaction with being in the perioperative space because as an anesthesiologist, I get to practice medicine in the way that I would like to.
Yeah.
Let's just say that. I don't want to say that I feel like a doctor again because there's going to be plenty of anesthesiologists who say, I'm perfectly
Fine.
happy.
Yeah,
like this
doing.
is exactly what being a doctor should be like. But I didn't find the same kind of satisfaction with that. Being able to look at a patient and not only give them education, and Jenna Blitz just gave a great discussion on shared decision making, right? That kind of thing really pulls me in and makes me want to come back. So, what are the patients saying? You're seeing more patients who are saying, like, nobody's talked to me like that before in the sense of really looking at me as a whole person. One of the patients the other day, I was describing to them how, and this was day of surgery, because perioperative optimization is perioperative. You don't have to always get to them ahead of time.
Yeah.
But I described to the family how we were going to be using some medications to reduce his chances of bleeding. So I was talking about tranexamic acid, and I was talking about having a lower threshold for transfusing him. But I also noticed that he was iron deficient, and since he was going to be he was going to be in the recovery room afterwards with an IV and being monitored, that I was going to give him an iron transfusion. They were over the moon about it. They were like, "Oh, great! So I may not get." Like, you are concerned about not giving me a blood transfusion, and I didn't want blood.
Yeah.
Not that I'm refusing it, but I just didn't want it. And I'm like, yes, we share the same goals.
Yeah.
Right? And I think that that's kind of what it gets down to. Physicians that are doing this are really describing to the patients that we share the same goals. We want you to be healthier.
Yeah.
We're looking at you as a whole person.
It's the triple aim.
Exactly right.
That actually
population health, patient health, and you've got to get the value piece right.
Yeah. Well, and then what is the quadruple aim? Adding the satisfaction of providers.
Yeah, and in England we have the quintuple aim.
Oh yeah. What's the?
But I'm not saying that. I'm not saying that
what's
there's
the
not.
fifth part?
There may be some financial uptick. You're never going to necessarily completely reimburse, but there's going to be the intangibles, right? And I do think that we've, for too long, focused on, well, we reduce delays and we reduce cancellations, and we have done those things. It's been really fantastic. And we have reduced length of stay. Patients don't necessarily care about that too much, right? But I think what you're also going to see more and more, as we start to do more innovative things, we're going to start to see, well, you can bill for that.
Yeah.
Right? So recently we've started the process of penicillin allergy testing.
We're getting ready to talk to Bobby Jean Schweitzer in just a little bit about that.
So a little more complicated.
Yeah.
Right? A little more complicated than it sounds, right? Initially, I was like, yeah, we'll just do it.
Sure, give a little people a
little prick. Did you break out? No, take it off. You know what I mean? A little bit more complicated than that, and we want to do it safely. So, but those kind of things, we've been offering flu and pneumonia vaccines this year in clinic. Those are all billable visits.
Yeah.
When you describe it in the vein of optimization and what did you do above and beyond data collection. So those can become optimized, or what we call, it's an E&M, or an evaluation and management visit, and we bill it as an optimization visit. And, you can recoup a little bit.
Yeah. Well, and I mean, in this world of value, people are like, oh, value-based care it's not here yet, so we got to figure it. It's not, but I mean, I think that we still need to talk about what we're doing to prepare ourselves for that going forward. And this is a huge value add.
Sure.
To the system, as a whole, to our patients. So I think that...
And if you want to get really innovative, right, not only are you doing this preoperatively, you institute a inpatient evaluation team, an inpatient optimization team. Because of the patients you're going to see in a regular day, you're going to see plenty of repeat inpatients, right? Those patients shouldn't be forgotten, right? And having that optimization team that are going around doing, let's just say, preoperative evaluations, but they're recognizing IVs, they're recognizing what the consults are saying, they're making sure that those patients are getting proper nutrition perioperatively.
Yeah, absolutely.
There's a lot of benefit in there. And so we've also have a pretty robust inpatient evaluation team at UAB that I'm super proud of, because what we're seeing now is we can now start to impact, sometimes even when we lose them sometimes in that middle ground.
Yeah.
And so this is a way that we don't lose them.
Now, Desiree, I'm sensing we're starting to run out of time.
We are.
Can I go off piste?
Oh, yeah?
So, like, we have a Jedi Knight of Twitter here, stays Dark Ops for 10 years, bursts onto the scene. Can I get your top 3 hints from your daughter that's...
Oh, yeah.
No, you've been tweeting these, right?
Everyone should know these.
Yeah.
The very first thing that she told me, she's like, you need to tweet about 3 times a day to be relevant.
Oh, my God.
About 3 times a day.
You're doing this, by the way, aren't you?
Oh, yeah, but I think I went overboard. Sometimes I tweet more. Look, I just
you are so relevant.
I'm so relevant that I just, on Twitter. The second thing that she was talking about is, and this is actually true, a tweet that is untagged is not a tweet. Okay, so
what does that mean?
That means you need to mention somebody.
Oh, yeah.
Right? If it's just a random musing that you just post.
It's got to have a hashtag or an at Jeff Simmons within it.
It needs to say, and there are tricks, right? If you're like...
you target people.
I really like water. What do you think, Jen Gunter? You know what I mean? And then 1 billion people read it because you like water. Then people are like, I like water too. And 9 new followers.
Yeah.
Because I love water.
You're hired.
Yeah.
You are now on Top Men Talk staff.
Yeah. And then you try to be authentic.
Yes.
Honestly,
absolutely.
You have to stay true.
Do you really like water?
Yeah, I mean, I just want to see if we relate.
Just checking.
Do you ever feel tired in the morning or hungry late at night?
Oh.
Do you ever feel a lack of energy?
We're going to tweet about that today.
Yeah, no.
All of those things. Those are going to be my 3 tweets today, actually. Good call.
But being authentic, I think, is really... And honestly, that is one of the reasons I love Top Med Talk. Just to get back to you guys.
Well, let's make it all about us.
I do want to get back to you guys. You guys stay on topic, and every day that I listen to it on the way home, because it's a perfect amount of time, and I do love hearing Monty go, Top Med Talk. You know what I mean? I tune in just for that.
Just to hear that?
Just for that part, and I love the roundtable. But we get into it, and you guys stick to topic, and I learn so much every day.
Oh, well, thank you for
You're
that.
welcome.
That is a very high compliment.
It's not bragging if it's true. So.
Well, you're saying it, not me. So, well, a testament to the power of social media and the power of voice and conversation and connection. I think it's really important. So thank you for all you're doing in this space, and look forward to hering about your accomplishments.
Thank you so much.
Inspirational. Very cool.
It really is. So good pointers there, not just for Twitter. Good pointers on pre-op optimization. And so I think that's great. So a couple points before we head out of this conversation. We're going to be talking to Bobby Jean Schweitzer here in just a little bit. Be sure to subscribe to Top Med Talk. Jeff, have you subscribed to Top Med Talk?
I am a subscriber.
That's
I've been,
awesome.
yes.
From the beginning. So
Platinum subscriber from the sounds of it.
So what?
Platinum subscriber.
Yeah, I think I put in a review. I gave you a 5-star.
Yeah, that's right. Thank you. That's a good idea. So 5-star reviews.
Yeah.
All right. Thank you for that. I appreciate it. Be sure to subscribe to Top Men Talk, though, if you haven't. If you have, we're going to send this to you, too. But we have developed now the Editor's Top Pick and the Periop Coach Series in box set, curated compilation. So if you haven't listened to Top Med Talk before, or even if you have, this is kind of the best of the best. Some things that we wanted to highlight that really speak to what Top Med Talk is. So keep a lookout for that whenever you subscribe to Top Med Talk. Also, and Jeff, we can put you in the running for this if you want. You could enter to win this bespoke, beautiful Marshall amp speaker. We're giving this away. Oh, absolutely.
Oh, I thought it was an antique that you guys were showing.
Oh, my God.
On.
I'm going to tell Monty you said that.
That's fantastic.
No, that's for real. This is awesome. So this is actually
I thought we were trying to make some ambiance or something like that.
No, isn't that cool? No, we're going to have a dance party later.
Oh, cool.
Yeah. Well, we have silent disco headphones, which is a whole other conversation.
I've got glow sticks.
Yeah. Oh, well, there you go.
They're warm because they've been in my pocket.
Oh, this is the scary conversation.
Too much information.
Yeah, way too. TMI. But anyway, subscribe to Top Men Talk. Be sure you have to follow us on social media. Follow at Jeff Simmons on social media.
Thank you.
And thanks for listening. And Jeff,
thank
you so much. It's awesome.
Great talking to you, Jeff.
All right.
Thank you.
Cheers, everyone. Thank you.
Top Med Talk.
Nick Majerison here. Have you got yourself onto edpom.org yet? If not, you might not be aware, EdPom Chicago tickets are free for a limited period only. Go now to edpom.org. Evidence-based perioperative medicine. edpom.org.